In this section of the YouTube video on QRS Complex, we're going to be looking at bundle branch block. My name's Darlene Hutton. I am the president of QRS Educational Services. So how do you know when there is a bundle branch block? First, and most important, there will be a P in front of each QRS complex, but the QRS complex will be wide, meaning it will be greater than 0.12 of a second. So in a bundle branch block, the problem isn't with the sinus node or the AV node. The problem is down within the ventricle. Either the left or the right bundle branch is blocked, and it's now going to take more time for the electricity to travel through the ventricles. Because of that conduction delay, the QRS complex will be wide. So a sinus rhythm with a wide QRS complex is your clue. There are different ways that patients can present when they are having a bundle branch block, and a lot of times we may just have a hard time remembering the difference between a right and a left bundle branch block. So let's first start talking about how to quickly and simply remember the difference between the two types. There are many leads on the 12-lead ECG that will be abnormal, but when you take a look at V1, V1 is always going to help direct you to making that decision. In a right bundle branch block, V1 will be predominantly upright with an R-S-R QRS complex. In a left bundle branch block, V1 will be predominantly going negative or down low. So upright is right, down low is left. Another method that I've used in the past, and I know people do like this one as well, so I'll share it with you, it's the driving method. Imagine you're driving in your vehicle and you come to the intersection and you want to take a right turn. How do you turn your signal? Upright. Likewise, you want to make a left turn. How do you turn your signal? Going down. So upright is a right bundle branch block. Down low is a left bundle branch block. So on this ECG here, you can see that there is a P in front of the QRS complex, so it is a sinus rhythm. The QRS complex is greater than 0.12. And when we take a look at V1, we have that typical right bundle branch block RSR pattern. When we take a look at this ECG, take a look, there is a sinus rhythm, so PQRS, but the QRS in V1 is going down. So this is a left bundle branch block. First thing that we need to remember is the most common cause of either type of bundle branch block is either coronary artery disease or perhaps an acute coronary syndrome like myocardial infarction. So we need to investigate those reasons. If the patient is asymptomatic, they will need a cardiac workup consisting of 12-lead ECG, an echocardiogram, some form of a stress test, and if the stress test is positive, then they will also need some diagnostic investigation, such as a diagnostic angiogram to determine the degree of coronary blockage or narrowing. Now, if the patient is symptomatic with a right bundle branch block, so let's say that they are having a myocardial infarction with ST segment elevation, you will most often see the presence of that MI with a right bundle branch block. But with a left bundle branch block, this is the conundrum that we have faced for decades. A left bundle branch block will hide or mask where the infarct is because the ST segment is already going to be elevated because the QRS complex is wide. If you take a look at the first video that we talk of in this series, I address ST segment discordance, which means that your ST segments will go in the opposite direction in a wide QRS complex. So in a left bundle branch block, it is normal to see ST elevation in the V leads, V1, V2, V3 at the very least. So the question is, does this ECG look like a patient that's having an MI, or is this just a left bundle branch block that is there for some other reason? So the current guidelines for management of a left bundle branch block is if the patient is having chest pain or equivalent, and we presume that this is a new left bundle branch block, we are more apt to initiate a code STEMI and at least consider the possibility of administering fibrinolytic therapy or getting them to the cath lab. If this patient is having a left bundle branch block and they're having symptoms and they are poorly perfused, such as in pulmonary edema or cardiogenic shock, then we absolutely need to activate code STEMI. We need to treat this patient knowing the reason they are in this situation is because they are having a massive anterior lateral infarct in all likelihood. In the next video in this series, I'm going to be looking at the cases that we sometimes see in a left bundle branch block with symptoms where we can actually make a confirmed diagnosis of ST elevation MI. So we're talking in the next video about the Smith modified Sgarbossa criteria. So thanks for listening. Please like and subscribe.